The first thing I need to do to answer that is let's define the rule. And the rule is if you're going to use an antimicrobial empirically to treat a urinary tract infection, this needs to be an uncomplicated urinary tract infection. And there's lots of things that will complicate an infection, but the most notable will be previous exposure to an antimicrobial. So if a patient has been previously exposed, and I don't think there's any good set rule about how long that interval would be, but my general rule of thumb is 3 months, then I think culture is important and you should not empirically treat. On the other hand, if you have a first-time infection, there's been no exposure in the household or in the patient to an antimicrobial, again assuming it's E. coli, and that tends to be the predominant organism causing infection in a dog, especially maybe Enterococcus in the cat, and the animal has clinical signs and you've made a decision to treat, you can probably assume that this E. coli is going to be susceptible to the drugs that it traditionally should be. In other words, resistance should not really be an issue. If that is indeed the case, then my first choice would probably be amoxicillin clavulanic acid, and that's in part based upon a study that we've done with 1,500 E. coli isolates, where we've demonstrated that only 22% of them are resistant to amoxicillin clavulanic acid, about 35% are resistant to amoxicillin, and a whopping 60% are resistant to cephalexin. And so if we want a drug that's excreted in the urine, and we want a drug for which resistance is not likely to emerge, amoxicillin clavulanic acid would fit that bill very nicely. I think we should avoid the fluorinated quinolones because historically data has shown if resistance does emerge, it tends to be multi-drug resistant, and if we have a patient that's at risk for recurrence of infection, we don't want that. Another drug is the potentiated sulfonamides. They, especially if you can use them for a short duration so we don't have to worry about the hypersensitivity or allergic reactions, they would be another good first choice for empirical therapy for a urinary tract infection in the dog. The one thing that I would add is because the half-life of amoxicillin is so short, and amoxicillin is what we call a time-dependent drug, where we want drug concentrations above the MIC of the infecting organism for at least 50% of the dosing interval, my preference would be to use the drug at 20 to 25 mg per kg 3 times a day. And we also should think about maybe crating the animal to make sure that the urine stays in the bladder for 50% of the dosing interval. Deciding on the duration of therapy is problematic because the science that supports our current approach of 7 to 14 days really doesn't exist. But conceptually, it makes sense to me that in an uncomplicated infection, if you use an appropriate dose and an appropriate interval, and again, the 25 mg per kg, let's say 3 times a day, then you should not have to use that drug longer than 5 to 6 or 5 to 7 days. And so my preference would be in the uncomplicated patient to try and use the shorter duration of therapy, 5 to 7 days, and then to look for the profession to generate some science to support these shorter dosing intervals for these drugs.